All right, here we are. Welcome everybody to the Naltrexone Myths live stream. We're back again with Dr. Joe Volpicelli, one of the leading expert on naltrexone, researcher, doctor, all things. Joe, right?
The Naltrexone doctor, yeah.
Yeah, the naltrexone doc. That's what I told him he should call himself. Um, So glad you guys are here. This is our second time doing this Myths live stream, and we were just chatting before we hit record. We have a huge list of naltrexone myths that we're going to continue to chip away at because we want to continue doing these live streams and talking about these things because it can really make a big difference whether or not someone can actually use naltrexone and get free from problem drinking if they understand the facts about it and what the myths are. So thank you, Dr. V, for being here. For those that don't know you, Dr. V, would you take a couple minutes just to introduce yourself so people know who you are and your background with naltrexone?
Sure. So I've been involved with Naltrexone research for, my goodness, 40 years or so. When I started working with rats, where we got rats to drink alcohol, and we found we could block uh, drinking alcohol in rats by giving them naltrexone. And then from that research, I conducted the first clinical trial at the Philadelphia VA to show that naltrexone helped humans. And data from that study went on to help naltrexone get approved by the FDA to treat alcohol addiction. And that was about 30 years ago. And since then, I've developed my sort of academic and clinical career to help spread the word about this medicine and to help people recover from addictions. And in 2008, I left the University of Pennsylvania, where I taught for 25 years. I was on the tenured faculty there. And 2008, I started the Institute of Addiction Medicine, which is a nonprofit entity dedicated to help teach people about effective treatments for addictions and to help educate the general public and healthcare professionals about it and to do research. And I also set up sort of a test program of how we could integrate evidence-based treatments into a real life clinical practice. So we call it the Volpicelli Center. And and so there we integrate using naltrexone and other medicines with good psychosocial support and other evidence-based treatments to try and help people in their recovery. And we learn from that, what works in actual clinical practice.
A question just popped in my head that I don't think I know about you. I'm curious if you don't mind me asking just real briefly, because I mean, I've been in this space since 2017 and it's rare to meet a doctor like you that is so passionate about naltrexone. I've talked to a lot of doctors that just don't really care, it seems, to be honest. I know
Yeah.
you know that. What is it about you? Like, why have you been kind of leading the way and just being so persistent with advocacy for naltrexone over the last 30 plus years?
Yeah, I mean that's a good question, and a lot of people who ask me that assume that I have some personal experience with drinking or addictions, and so
Exactly.
that's why I'm passionate about it. But actually, of all the problems I have, and I have problems, addiction is not one of them, except for my addiction to corn chips. So, so for me, it was always something that stimulated my curiosity, and I've always been interested in causes that people have thought were hopeless, causes that people thought that there is no effective treatments for. And I guess I have something in my personality where I want to show that people are wrong about that sort of thing. And so when I got involved with doing rat research, it was people told me you can't get rats to drink alcohol, and then we showed we could do that. And then they said, well, there's no effective treatments for alcohol addiction except for going to AA meetings, and I showed that that's wrong too. And now they're saying that we can't get people to use naltrexone, and that it's poorly understood. And now I want to prove that wrong, and so that's why I'm on here with you to try and dispel myths and to get the word out about this medicine. So I've
Yeah.
always been curious, and for me, the field of addiction is just it's so fascinating that I think it was Osler who said that if you knew syphilis and all its manifestations, you knew all of medicine. And in that day, there was no effective treatments for syphilis, so it would manifest itself in terms of neurological problems, problems for every organ system, and it's sort of the same for addictions. If you know about addictions, you know all about psychology, you know about physiology, neurochemistry, and public health. And so I like to dabble in all those areas. And so it's been fantastic. It's been a great journey. And I've loved working with patients and seeing how they make progress and love the challenges involved in the field. So for me, it's just been great. Loved every minute of it. And people say, when are you going to retire? And for me, this is my retirement, is to express my passion for something that I feel strongly about.
Yeah. Well, it shows, and I'm so glad that our paths have crossed, certainly, because you've taught me so much about naltrexone since I met you. And, I feel like I knew a lot through my experience with it and just being in the field. But yeah, it's really nice to have someone of your caliber just like advocating for those of us who are like, why isn't this treatment more well known? I think every person that learns about it asks that question, to be honest. Yeah, so
And
just welcome. Oh, go ahead. Yeah.
let me just say that, you know, the people that I meet who are in this area, and particularly people from grassroots and people with lived experience, has just been really inspiring for me. So people like you, Karen Dion, Steve Wagner, et cetera, that has just really been wonderful to see that kind of enthusiasm that people have and passion that people have, and the people have used naltrexone to help them in the recovery. That they feel, many people feel passionate about getting the word out, and it's just been exciting for me and helps fuel my passion when I see other people being so passionate about this.
Well, good. Yeah, you're not on your own out there. I know you've hit some walls like in academia and just things I've heard from you about you trying to talk about this amongst your peers, and it hasn't always been well received, I guess you could say. Well, again, I just want to welcome everyone. What?
It's been challenging at times.
Yeah, but here you are. Just want to welcome everyone again. We're streaming on several different platforms, so wherever you're coming from, welcome. Last time we did this live, some people had questions. I see we've got one in the chat, so we will try to get to some of your questions as well, absolutely. But I do want to start with the first myth we were going to cover today, Dr. V, because this is such a common one that we hear all of the time, and that is that when you take naltrexone, it's blocking all pleasure. So if you're on it, maybe you won't enjoy life or other pleasures, maybe you'll feel depressed. So tell us why that's a myth and what the facts are behind that.
Well, I actually saw a nice short on YouTube today from someone who described it perfectly. That was you, and so I want to get your input. But I have to just say that when we did the very first study with humans, one of the things I was really concerned about is maybe this medicine would block pleasures because it blocks the endorphin system, and the endorphin system is involved with reward and pleasures. And when the endorphin system is stimulated, it increases dopamine activity, and that's certainly a neurotransmitter involved with reward. And so I was really concerned that if I blocked the reward from alcohol, I would block the reward from other pleasures, and then it wouldn't be a very effective medicine. Yeah. So anyway, when I did the first study, I monitored people very carefully to see how much they enjoyed other things in life. And what I found was, and to some extent it was surprising, is that they said it didn't block other pleasures. They were still able to enjoy a good meal. They were still able to enjoy social activities. They were still able to enjoy intimacy. They were able to enjoy other things in life. In fact, by drinking less, they had more time and interest for enjoying these other activities. So it enhanced their enjoyment for other things, not took it away. Now, I have to say that there were certain exceptions to this. And the exceptions, I think, tell us an important story. That I had one patient who was from India, and he loved hot, spicy foods, like really hot, spicy foods, the kind that would bring tears to your eyes. And on naltrexone, he didn't enjoy it as much. It was more painful than fun. I also had another patient who was an ultra marathon runner. So he didn't run just regular marathons. He would run 50-mile marathons, and he would go through a pair of sneakers every couple of weeks. Mm-hmm. And on naltrexone, he found that he didn't enjoy that as much. He cut back on his running. Now, that's a situation where I wonder if his running actually turned into an addiction, because I know that there were times when he sprained his ankle or his foot or something, and he would still get out there and run. And if he couldn't run for some reason, he would actually go through, he would say, withdrawal.
Ha.
And so on the naltrexone, he was able to do it, still enjoy it, but he wasn't so much into the ultra marathon running. So there may be certain conditions where the naltrexone does block, quote, pleasure from things, but it helps bring things more into moderation, and that may be an overall good effect anyway. So if you, when I looked at my empirical research, and I had questionnaires that assessed people's enjoyment and things, we found that there was no effect. But Katie, why don't you talk about your experience on naltrexone, and did that affect your pleasure or enjoyment in things?
No, and to be honest, that wasn't even a concern on my radar when I started because it made sense to me. I was taking it to target the pleasure from alcohol, and I didn't think about it impacting pleasure in other ways. And just looking back, I don't, yeah, I never noticed any impact on pleasures I enjoyed. In fact, what I found was on my alcohol-free days when I was pursuing other pleasures and I didn't have naltrexone in my system, it was as if like I was like remembering, oh, there's other ways to have joy in life because I was so hyper focused for so long on alcohol as the primary reward and pleasure in my life for nearly 10 years. And so um, I didn't notice naltrexone hindering pleasures at all. And in fact, like it felt like the opposite, where I was like, oh, yeah, there's other ways to enjoy life. And I always appreciate what you told me, which stuck with me about it being the pleasure center in our brain being more like a symphony to where
Mhm.
it's not like you take naltrexone and all those pleasure receptors are blocked. Did you want to talk a bit more about that analogy?
Yes, a lot of people say, well, if you block dopamine or you block endorphins, you're going to block pleasure. But I think it's much more subtle than that when
Yeah.
you really talk about what pleasure is. And I like the analogy of a symphony orchestra. If dopamine, endorphins are the horn section of your symphony, sometimes that can be so overpowering that you lose the joy of listening to the string instruments.
Yeah.
And so what naltrexone does is it sort of brings it back into balance, so you can get the whole flavor of joy, the highs, the more subtle parts, the relaxation, the energizing effects. And that's what gives you, I think, the real sense of pleasure. I was thinking of another analogy today. Um, I enjoy a good beef stew. I know you have some experience in France and all, and maybe you have that experience too. But what makes it so good is the mix of various ingredients. And if you have, say, if you like to put a little bit of salt in your beef stew, a little bit enhances the flavor. But if you put too much, it overpowers the whole experience and it's not pleasurable anymore. And the same thing for any ingredient. If it's too much, it messes up the pleasure. It's that balance
Yeah.
that plays off the other. That's what makes something particularly tasty.
Yeah.
And same thing with a symphony, with music. It's the interplay of various components and how it changes dynamically over time. And that's what I think pleasure is. So it's way too simplistic to think of a pleasure center or a pleasure molecule, and blocking that would reduce your pleasure. It's
Yeah.
it's the interplay, the dynamic changes over time that I think give you a sense of joy and pleasure.
Yeah. So, just in conclusion, so people can understand, the times you've seen naltrexone impact pleasure, it's more of the pleasure that is associated with pain, like the spicy food or the ultra marathoner, but with other pleasures, it doesn't seem to hinder that for people. Is that right?
Yeah, so the natural stimulus for the release of endorphins naturally
Yeah.
is pain.
Yeah.
So your
So interesting.
body, in its infinite wisdom, says if you're in pain, we're going to compensate for that by releasing endorphins. And some people engage in painful activities to get that endorphin effect,
Yeah.
and they do it maybe even willfully to get the endorphins going. So they tolerate the pain to get the endorphin effect. But sometimes that can lead to bad effects, that you can get addicted to it, and that becomes the sole source of your pleasure. And
Yeah.
I think that's a mistake. I like to think life more as a smorgasbord, that there's a variety of things on the plate to try,
Yeah.
that you don't want to just eat I had one patient who used to eat baklava all the time. Just, you don't want your whole diet to be baklava. It might taste good, but that's not what you want your whole diet to be. Enjoy the full range of pleasures that are out there, and naltrexone allows you to do that. Now, I do want to make one other point.
Okay.
Some of the people who may be listening are using the Sinclair method and have been taught that it's better not to take naltrexone every day because it reduces your pleasures on the days that you take it, right? So I don't know of any good evidence that that's true. And for some people, they take the naltrexone every day, and it not only helps them when they do drink to limit how much they drink, but by taking it every day, it helps to extinguish the cues associated with drinking. It helps people overcome that sort of obsessive thinking about alcohol.
Yeah.
So it's important to keep in mind that naltrexone is a pretty remarkable molecule that has a variety of effects to help people in recovery.
Yeah.
And dogmatic statements like you should always do this or you should always do that, I usually don't favor that sort of thing. Do favor you should always take your medicine. That's an important one.
The one
But
rule.
that's a golden rule. But aside from that, how naltrexone can be useful and helpful for people really varies for different people. And so I wouldn't say that one must not take naltrexone on days where you're not going to drink.
Yeah.
And that's one of the rules that I think people have. And I think that's a myth. I think it's okay to take naltrexone even on days where you don't plan to drink, because it might help you control your craving, where you can again focus on other things besides that obsessive in the back of your mind thinking about alcohol, even if you're not drinking.
Yeah. A challenge I come across working with people is, and I think this is maybe more like a psychological or mindset thing they need to work through, but they'll tell me that if they've taken naltrexone, they feel like they have permission to drink. So if they're planning to have an AF day and they take naltrexone, they're like, well, I might as well just drink. Now, not everyone struggles with that, but that does seem to be a common theme that comes up with some people, where if they've got it in their system, they kind of feel like it's an open door to go ahead and drink. I don't know if you have any thoughts on that.
Yeah, so sometimes people get the mistaken impression that if you take naltrexone, you must drink. Don't take the naltrexone and not drink. And that's, again, not necessary.
Yeah.
But some people, if they take naltrexone, that may give them permission to drink. And again, we're not telling people to drink or not drink, but what we say is that naltrexone helps you be the boss, you be the agent. So it's not that the alcohol controls you, but you control the alcohol.
Yeah.
And some people volitionally say, I want to drink. Maybe I even want to drink a lot. And naltrexone won't keep you from doing that. It won't make you sick. It's not like antabuse that'll make you sick. It won't prevent you from drinking. That's another myth that people have, that it will prevent you from drinking. Does not do that. It just puts you in the driver's seat.
Yeah.
And if you want to drink, you're able to. You'll still get some effects from the alcohol, but you'll be in a much better position to stop after one or two drinks, if that's your choice.
Yeah. Yeah, I like that. Naltrexone makes you the boss. Okay, so I think we have a couple questions here. Thank you. I see Neil and is it Givato? Sorry if I said that wrong. So we'll pause the myths list right now and jump to this question from Neil. So he says, you previously said some people need more than 50 milligrams of naltrexone. Do people ever need or do better on a lower dose? I found 25 milligrams worked really well, but moved up to 50 as that's the protocol.
Yeah. So again, my philosophy is that treatment needs to be individualized, and knowing something about the pharmacology of alcohol and its pharmacokinetics, I know that there's huge individual variability in terms of how the naltrexone gets metabolized. Yeah. And I'll give you one statistic, one example. If you take naltrexone orally, it gets absorbed in the GI tract, and then it goes to your liver, first pass metabolism in the liver, and that's where the naltrexone gets broken down. Now, for some people, up to 90% of the naltrexone that you take gets broken down in the liver before it ever gets to the brain and has an effect. For other people, it's 60%, but a huge amount of naltrexone gets broken down before it ever gets to the brain. Now, if you're one of those folks that most of it gets through, then you're going to need a lower dose of naltrexone. If you're one of those people that most of it gets metabolized, you'll need a higher dose.
Yeah.
And so the right dose is a dose that works for you. And it's a play off between what's effective and potential side effects. And so you need to find what what particular dose is effective, and 25 milligrams might be perfectly fine. So I wouldn't worry about having to uh, adjust your dose based on what someone said in a book at one time. I would adjust the dose based on what works for you.
Mm. And I know you've talked a lot about this, Dr. V, where sometimes we have this belief that, oh, I'm a big 250-pound man. I must need a lot of naltrexone. Can you talk about what may or may not be true there?
Yeah, so it doesn't really depend on your size. So something like alcohol really depends on your body composition. So if you look at the blood levels of alcohol for women, for example, it's often much higher per drink than it is for men, and it has to do with lipid solubility and physical size, that sort of thing. But for naltrexone, the rate limiting factor is really how naltrexone gets metabolized. And some people just have a system, how their liver is genetically put together, where they
Hmm.
metabolize the alcohol very quickly, right before it even gets to the brain, and other people don't. What's the right dose? Again, it depends on the person, but I'll give you a couple of generalizations that may be surprising. In my clinical practice, again, this isn't proven in scientific research. This is based on my clinical practice, and please help hold me accountable, Katie, if you find that I start speaking of something as true when it's just based on my clinical experience. So sometimes I'll say things that are based on evidence, research evidence. Some things I'm going to say that are based on my clinical impression. What I say based on my clinical impression in $5 buys you a cup of coffee. That's how valuable it is at Starbucks. What I say that comes from scientific research, that has some weight behind it. Okay. So having said that, based on my clinical impression, I often find that women need higher doses than men. I don't know why that is. I don't know if it has something to do with the menstrual cycle. I don't know if it has to do with the way by the way the naltrexone is metabolized. But I often find that women, I have to push the dose up above 50 milligrams, more like 100 milligrams to get a good effect.
Hmm.
So take that for what it is. Again, it depends on the individual, and you might be surprised that body size, is not a very good predictor of what the right dose should be.
Perfect. I think that's pretty clear. Hope that's helpful to you guys. Okay, I see this other question we have. They say, good evening. You must be somewhere in the world where it's evening. Hello. So they say, I'm 8 months on naltrexone and still about 200 drinks per month. Should I worry for not achieving significant reduction? Cravings gone, but habit is still a problem.
Oh, okay. Cravings on, but still a habit. Okay, so what naltrexone is especially good at is reducing craving, and again, putting you in the driver's seat where you get to decide. And so, for someone who continues to drink but they're not craving the alcohol, then my question is, why are you drinking? And there's a variety of reasons why someone might be drinking, and you say it's habit, that you do it maybe without thinking about it, that it's just something that you normally do. And Katie, I think you have a lot of suggestions for this sort of thing. So hopefully you can help answer the question too. But in general, the naltrexone doesn't keep you from drinking. So you need to take some willful attention to dealing with the alcohol issue. I'm going to quote you, Katie, that it takes you part way there. Actually, you should
Yeah.
probably give the quote, but it doesn't do the
Meet the
whole work.
medication halfway.
Meet the
That one?
yeah, there you go, perfect. Meet the medication halfway. So, and there's various mindful techniques that you can use, like you record your drinking, or you break up your habit. So if some people drink at 5 o'clock every day, and they're just used to pouring themselves a couple of glasses of wine, and that's what they do when they don't think about it. So break it up. Don't have any wine around. So if you want the wine, you have to go out and buy it. And by putting that time between the habit and engaging in the behavior, it gives you time to think about, do I really want it?
Yeah.
I have other patients who I have write down the reasons why they don't want to drink and put it in a 3x5 card and keep it in their pocket. And then when a situation presents itself where they would normally drink, I have them pull out the card and read it and remind themselves why they don't want to drink. So there's a variety of techniques that you can use. But Katie, I think you have a lot more experience with working with people on that issue than I do. So why don't you give your advice?
Well, no, I mean, I think you're exactly right. And I will say sometimes people try to change the behavior when really step one should be changing the internal thoughts and beliefs about alcohol. Like Dr. V said, why do you want to drink? And habit's an easy thing, but we got to get underneath that and understand, why is this habit perpetuating even if I don't really want it? Like, why am I eating a whole tub of ice cream in front of the couch or in front of the TV when I'm not even hungry? And to understand the real reason underneath that, we have to understand what our thought life is like and what our beliefs are about alcohol. I know for me, there was honestly fears around, who will I be if I'm not drinking every Friday night? What will I do with my time? I don't have hobbies. I'm just bored. And so getting these little nuggets of insight was helpful for me to at least understand the reason why. And then the question I would ask myself is, okay, I have this need right now. I'm bored, for example, and my automatic behavior is to drink. So how can I think about other ways to meet that need? Okay, lots of people are bored and they don't drink. So I know that's objectively true. So let me make a list of things I could potentially do instead of drinking to combat boredom. And for me, the way I started with that was I just started small. I'd say, I can drink later today if I want to, but first I'm going to do this thing. Because sometimes, forcing myself to be alcohol free was too much of a stretch that day. So it was like drinking was just delayed a bit and I was doing something else instead first that could potentially be what I would do instead of drinking. I would recommend too, just getting any habit change book. Like I read Atomic Habits, and I think that's a perfect complement to TSM because it provides really practical ways to change habits. And if you read any habit change book, I think one of the themes that connects them all is these tiny changes, but done with consistency. So recognizing that you're not going to change your habits overnight, but what's one small thing you can do today that, as it says in Atomic Habits, you cast the vote for your future self. So what would I do today to have a better version of myself tomorrow? So that's my 2 cents on the topic. Hope that helps. But so many people struggle with the habits. They really do. I hear people say all the time, I don't really want to drink, but I did it anyway. And when alcohol's been our BFF for years or decades, it's a habit we have to break. But the really cool thing is, as humans, we can change habits. We're not stuck there. And it's just little steps done with consistency.
Yeah. And I would ask, what else do you enjoy doing? And try to substitute that in there. So
Yeah.
We can get to that later, but I have another analogy that I'll talk about later.
Okay. Okay. Okay, so we got another question in here from Marie. Would you like to do that and then we'll jump to another myth, Dr. V?
Sure.
Okay, I'm going to read it. Hi, Kitty and Dr. V. Thank you so much for offering this information through live stream. You're welcome. We're glad to be here. I have a prescription for naltrexone. Tried for a few days, but stopped due to side effects interfering with work. If I start again and take it daily, what would be the best time of day? Usually an evening drinker.
Okay. Well, first, let me say a word or two about side effects. That typically the side effects from naltrexone are mild and occur early in treatment and generally go away over time. I don't know. Has that been your experience working with people?
Yeah, for sure.
Yeah. And so what I would say is try and hang in there, and the side effects should improve. But what can you do? So one of the most common side effects is nausea. Okay, I don't know what not kidding, Marie. I don't know what your side effect is, but if it's nausea, there are things that you can take to help reduce your nausea. For example, I often write for a medicine called a Dancetrone, and that can help reduce your nausea. There are other things that you can do. So the side effects are probably related to how quickly the naltrexone gets into your system. So if you take naltrexone with a meal, that's going to slow its absorption, so it won't get into your brain so fast. So that might help to reduce some of the side effects. Some people take it at night because then they avoid the side effects or sleeping when they have the side effects. But the problem with that strategy is you might not have a sufficient level of naltrexone in your system when you're drinking the alcohol. And so the question of when's the best time to take the naltrexone is you want to time it so that you hit sort of peak levels at a time when you're likely to drink. And that's between 1 and 2 hours before drinking. So that's probably the best time to take it. But if you're trying to take away side effects, try and add a meal. There's some medicines to deal with some of the side effects. Be patient, and it'll generally go away. Reduce the dose of naltrexone. So there's a variety of ways of working around the side effect issue. And I would say is the primary thing is don't give up on the naltrexone. Just figure out a way around the side effects, and you'll probably find over a period of time that you feel better. I don't know. Is that your experience working with people, Katie? Or
Yeah, that's absolutely. Yeah. So many people, I've worked with people that even had severe side effects, and their doctor had them start at a lower dose, and they just slowly worked up and they went away completely or mostly. And so I always tell people, of course, work with your doctor, but in my personal opinion, there's no rush to get up to 50 if you're feeling sick at that dose. Like my doctor had me stay at a low dose for a little while, and then I gradually worked up. But yeah, the food really helps. People take an anti-nausea medication with it sometimes. But for most people, the side effects go away from what I've seen. Yeah, and a couple of people in the chat are talking about how their side effects disappeared too.
there you go.
I had a client once, actually, I'll say this anecdotal story, because they had side effects and they noticed if they drank a full glass of water with it and had a snack, it really helped. And
There
he'd
you
been
go.
on it for a while, wasn't having side effects, but didn't have water one time when he took it. So he just swallowed the pill and he had side effects, even though he'd been on it. So for him, he needed that full glass of water to help with the side effects. Just one little anecdotal story.
There you go.
And she says her side effects are nausea and sleeplessness.
Oh, okay.
Yeah.
Well, then I probably wouldn't take it before going to bed.
Yeah. But hang in there. Hopefully that helps you have a good understanding of what to expect, and that they should go away with time.
Yes.
And hopefully, yeah. Okay, so next myth we're moving to, naltrexone prevents you from getting drunk. Therefore, if you drink on it, you will overconsume alcohol since you can't feel the intoxicating effects of alcohol. What's the truth behind that one, Dr. V?
Yeah, so that one is wrong. So that's a myth. And it's important to understand that alcohol has a variety of effects in your system. So one of the effects, and the one that we think is most important for understanding addiction, is that the alcohol can stimulate the release of endogenous opiates, which in turn increases dopamine, and that gives you a sense of motivation to want to continue to drink. That's one effect. But alcohol also has sedative effects, so it slows down the nerves. And that effect is not blocked with naltrexone. And so you'll still get tired, and you can overdose, you can slow down your breathing, you'll get all those bad effects. So typically what I find is that people, when they take naltrexone, they're surprised that they don't get the energizing effects first. They immediately go into the sedative effects. Now, some people may think that I just have to increase the alcohol drinking to get those stimulating effects. But usually they discover very early on that no, they're not going to get the stimulating effects, even if they increase their dose. And they might try that experiment once or twice, but they quickly learn that that's not going to work to give them the energize, the high, the euphoria.
Yeah.
I had the same argument with using naltrexone to treat people who have opiate addiction. That people who didn't like the idea of using naltrexone would say, well, if someone doesn't get the high from the heroin or whatever, they'll just keep pushing the dose up until they can overcome the effects of naltrexone. And so that's why naltrexone is not a good strategy to treat opiate addiction. But in point of fact, I found that typically was not a problem, that even people who tried the experiment by increasing the dose, they couldn't get that euphoria that high. And I can go through the pharmacology a little bit about that, but it looks like the euphoria that people experience has to do with how quickly those opiate receptors are stimulated.
Huh.
And if you have many of the receptors blocked with naltrexone, no matter how much heroin or opiates you take, you're not going to get that big rapid increase in opiate receptor activity. So it's going to blunt the euphoria that you feel. And really, that's sort of the mechanism of how methadone works. It stimulates all the opiate receptors, but it keeps the receptors maximally stimulated constantly. So there's no euphoria
Huh.
when you're on methadone. So it's not the absolute level of opioid receptor activity that gives you the euphoria. It's the change from a low level to a high level. And if you can't get to that high level, you're not going to get the same euphoria. So one way of not making sure you don't get to that high level is by blocking some of the receptors with naltrexone.
Okay.
No matter how much heroin you take or how much alcohol you drink, you're not going to get that high. Alcohol has the additional advantage that the sedative effects will kick in, so you'll just get tired.
Yeah, I feel like in my experience, naltrexone just made me a normal drinker. Because normal drinkers, I know you've told me this, Dr. V, that when normal drinkers who don't have a problem consume alcohol, they have a couple drinks, but then they just feel tired and they don't want any more. That's why they have an off switch. And for those of us with AUD, it's like those couple drinks motivate us to keep going and going and going. But with naltrexone, it just changes that over time. And I would have 2 drinks and I'd be like, no, I don't want a third. I'm done. That sounds, yeah.
Yeah, I can share an experiment that we did where we brought people into the lab and gave them 3 beers. And these were people who didn't have alcohol addiction. They were actually college students, but some of them had a strong family history for alcohol addiction and some did not. So the people who had the strong family history for alcohol addiction, after 3 drinks, they felt increased energy. They felt euphoric, and their craving for wanting to have the 4th drink was higher than the craving for even the 1st drink. The people, and then after about 45 minutes, then they went through a phase where they just started feeling more tired. The people without a family history for alcohol problems, they never got that stimulating effect. They mostly just got tired. So that kicked in sooner. And after 3 drinks, they were done. They didn't need any more. They had their fill. But the remarkable thing about the experiment was when I gave them naltrexone before drinking, the people who didn't have a family history, the naltrexone didn't affect their drinking. They still got tired. They just said, I don't know, this feels like placebo. It doesn't affect me one way or the other. But the people with the family history, the naltrexone blocked the stimulating effects from the alcohol. So they looked just like the people who didn't have the family history. They got the tiredness right away, just like the people who didn't have the strong family history.
Interesting.
And their craving was blocked. After 3 drinks, they were not psyched to have the 4th drink. They look like, quote, normal, quote, drinkers, if you will.
Yeah.
But
Interesting.
again, these are people who weren't addicted to alcohol, but they had the gene for it. And real early, you could see that maybe they're going to be at risk for having alcohol problems. And for me, it suggests that maybe we need to intervene earlier by identifying people who get that stimulating effect. They may be the individuals at risk for having alcohol problems later in life, and perhaps we can intervene earlier by giving them naltrexone before they drink to prevent that from happening.
That would be so cool to prevent it. That would be wonderful. Just real quick, back to the people believing naltrexone you can't get drunk on naltrexone. I think that perpetuates because sometimes in articles it states that naltrexone blocks the buzz from alcohol, and people might confuse that with intoxication, and I could see why they would.
Right. Yeah.
But the buzz to me, it was like just that euphoric giddy effect that made me chase the next drink. It just kind of dampened that a bit. Yeah, so just wanted to say that. And Marie is asking what anti-nausea meds will not cause drowsiness. One of our coaches, she uses non-drowsy Dramamine. I know some people use Zofran. Anything you know of, Dr. V, that you want to share?
I mean, just find the right medicine that works for you. And I should point out that, and we should have probably pointed this out from the beginning, that it's good to talk to your doctor about these
Yes.
things. Yeah, that I'm a doctor, but I'm not your doctor. And so what I say is general advice. It's not specific advice for you.
Yeah.
So if you have issues, talk to your doctor about it. And particularly for dealing with side effects, your doctor will have some good suggestions, I'm sure, to help you with that.
Yeah. Yeah. We can't give medical advice here. Obviously, I'm not a doctor, but hope the information is helpful. Okay. I see this question. How toxic is naltrexone? That could be another myth we could.
Do we do that one yet? Or if we didn't, that's a huge myth.
I think we talked on it being dangerous to drink on naltrexone. So let's
Oh,
bust
okay.
that myth. How toxic is naltrexone?
It's not, but
It's not. Let's move on. No.
This is one of those things that really gets me going. I watch myself on YouTube and I come across as really boring. I know that somebody said Dr. V talks too slow. I saw that comment one
Are
time.
you serious?
So,
you can speed videos.
But this
up,
is one of those issues that does get me excited. I'm going to speak fast now. There is a myth that doctors believe and has been, communicated to patients that naltrexone causes liver disease. It's bad for you. It's toxic. And there's a kernel of truth to that. But the conclusion is completely wrong. And the kernel of truth is when we started doing studies with naltrexone, there was a study done with people who were obese, and they gave like 300 milligrams a day to these people. They found it didn't help with their obesity, but a couple of them had elevations in their liver enzymes. Based on that, when naltrexone was approved to treat opiate use disorder, there was a big black box warning, don't use naltrexone, it can cause liver disease. That was in the beginning. Now, and I was worried about that when I did the first study. And so I tested people's liver enzymes before they started the study. And if you had elevations in your liver enzymes, I wouldn't even let you join the study. If you had more than 3 times normal liver enzymes, I said you're not appropriate for the study. And then every single month, I would check their liver enzymes. And what I found was that the people on naltrexone at the end of the study had lower liver enzymes than the people who got placebo. And that's because they were drinking less. Because alcohol does cause liver damage. Naltrexone doesn't cause liver damage, but helps people drink less, so you have improvement. So people said, okay, we'll just follow along and make sure we'll check the liver enzymes all the time, and it's probably safe to give to people with alcohol problems. And then there would be all kinds of recommendations that you always have to check the liver enzymes first, make sure you never go above 3 times normal, that sort of thing. Well, I began to loosen up my criteria, and I would give it to people with elevations in liver enzymes, and they did perfectly fine. I stopped checking liver enzymes every month. People did perfectly fine. But then they said, well, if you really have significant liver disease, you shouldn't take naltrexone. Now, I didn't have any data to refute that. Now I do.
Now I've got the ammo.
Now I do. The gastroenterologists, the people who treat individuals with liver disease, started using naltrexone. And they started using it because it helped reduce itching in people with severe end-stage liver disease.
Huh.
But then they found people were drinking less alcohol. And so they said, all right, let's give people naltrexone because most of the people who come in with failed livers have failed livers because of excessive drinking.
Huh.
So anyway, they went back and they looked. I think there was a study done at the VA where they looked at people who have severe liver disease. And they went back and looked at the medical records, and they looked at the people who got prescriptions for naltrexone and the people who didn't get prescriptions for naltrexone, and they looked to see actually mortality, who lived and died. And the people who got the naltrexone prescriptions, all-cause mortality was less. They were living longer. So not only was it not toxic, but it helped promote people living longer. And I think the reason is it doesn't have bad effects on the liver, but what it does do is it reduces your alcohol drinking, which is really good for the liver.
Yeah.
So the data show, so this isn't just clinical impression, this is the data, show that even with severe liver disease, it's okay to take naltrexone. Now, there's going to be one exception to this, and that is for some people who have acute liver disease, hepatitis, something like that.
Yeah.
That could be a problem for this reason. What did I say? Naltrexone, when it's taken orally, first thing it does is it goes to the liver where it gets metabolized. So if your liver's not working at all, the organ that helps metabolize the naltrexone isn't going to be working. And so we're not sure what's going to be the right dose, and a dose could accumulate, that sort of thing.
Hmm.
So if you have acute liver disease, you have to be really careful about using naltrexone because the organ that metabolizes the naltrexone is not functioning well. So
Is that where Vivitrol would be better, or is that the same issue?
Well, the naltrexone, Vivitrol is an injection form of naltrexone, so it doesn't go to the liver first. So that's one of its advantages. But you still don't want to have a buildup of naltrexone in your system, so you still want some way of getting rid of it. So you probably the dose is going to be very different. So you have to be really careful. So if your liver is not functioning, then you have to be really careful with using naltrexone. But people have chronic liver disease, but their liver is still functioning, so that they have scarring tissue, that sort of thing, but it's still working. Then it should be perfectly fine to take naltrexone. More than perfectly fine, it's probably promotes life. It increases your chance of survival.
That's so encouraging to hear.
And then people would say, well, can you overdose on naltrexone? Never heard of a case. I'll give you an example.
Dr. Umhau tell us a story?
I'm going to give you an example, exactly. Or you can tell a story.
No, I don't. You tell it, because I don't remember all the details.
There is a woman who had, I think, opiate addiction, alcohol addiction. She was prescribed naltrexone. I think she wasn't taking it, or she took it and it wasn't working. And so then I think something happened in her life, some crisis, and she says, I can't take it anymore. I'm going to kill myself or whatever. So she took a whole bottle, 30 of the 50 milligram naltrexone. So what's 50 times 30? It's a whole lot. She took it all at once, the whole month's supply in one sitting. So what happened to her? So if you're going to overdose, that would be the thing to overdose on. What happened to her? She stopped drinking, stopped using opiates. So they brought her into the hospital. They checked the liver enzymes. They were fine. She looked perfectly normal, except now she lost the desire to drink and use opiates. So for the next couple of weeks, she was really good. Then I think she didn't go back on naltrexone and started drinking again or something like that. But the only thing that happened to her was she didn't decide. She just stopped drinking, stopped using opiates. But there was no horrible effects on the liver and no other horrible, terrible side effects. Now, having said that, people in the opiate field would say, oh, naltrexone is dangerous, that people can overdose on opiates on it. Let's look at the data. If you look at the number of people who overdose on methadone or overdose on buprenorphine, it's much higher, much higher than overdosing with naltrexone. Number one, you can't overdose on naltrexone, but they'll say somebody who stops taking naltrexone and then uses opiates, they will have lost tolerance to opiates. And so even a small amount will cause an overdose. And it's absolutely true that if you stop using opiates, you'll lose tolerance. Then if you go back to the usual dose of opiates that you use, there's a chance you could overdose. But the number of people like that is small compared to, somebody getting into your buprenorphine supply and overdosing, somebody using too much methadone, methadone being diverted to the street. So if you look at the number of people who overdose from buprenorphine and methadone, it's much higher than theoretically somebody overdosing because they lost tolerance to opiates, and then they go out and use their usual dose, and then they overdose because they didn't understand that they lost their tolerance. That's a theoretical reason that naltrexone could have bad effects, but it's the number of cases like that is relatively small.
Wow.
Of all the medicines that I prescribe in psychiatry, antidepressants, benzodiazepines, Neurontin, every medicine that I prescribe, naltrexone is the safest. Can't overdose on it. Doesn't have terrible effects on the liver.
It's not addictive.
Not addictive. Yes, exactly. That's another one of those myths that, it's addictive. None of those things. It's really safe. So, is it toxic? No.
Period.
Period.
Well, so this next question kind of ties into that, and it's actually one of our myths. The question is it safe to use long term? And the myths we have around that, which I've heard these stories a lot over the years, where someone's doctor will only give them like 3 months of naltrexone because it's not safe to take long term, or because they believe if it doesn't work after that, then it's just not going to work for you, period. So I guess let's talk about that, whether it's safe long term. And I guess go ahead.
Oh my God. Yeah, that's a great myth. And I'm looking down and I see we only have like 5 minutes to go. And I have like about a 20-minute talk on this issue. Oh my goodness. Oh my goodness. Is anybody still watching us? Okay.
The self-deprecating humor is just great. You're just talking to a wall here, Dr. B.
It's whenever I come on, the number of people watching starts going down. When you're on, they start going up.
Okay, naltrexone, doc.
I'm sorry, Katie, but I do have to answer the question.
Yeah.
Okay. Now, my scientific cap. What is the real data? There isn't good data about how long you should be on naltrexone. There isn't good data. There's one study that was done by me where I had 3 groups. I followed people for 12 months. In one group, they got placebo for 12 months. Another group got naltrexone for 3 months and then placebo for the rest of the study. Another group got naltrexone for 6 months and then placebo. And the group that got naltrexone for 3 months compared to placebo, they looked great during those 3 months. But when I stopped the naltrexone, and they didn't know we stopped, we just switched the pills. That group gradually started looking like the group that started on the placebo in the beginning. Okay, so 3 months, not enough. Then the 6-month group, they continued doing great for 6 months and then stopped their naltrexone. But then they took placebo for 3 months. They still look good during that 3-month period. So it looks like 6 months is better than 3 months. And then there was 3 months where no one got any pill, and I looked at their behavior, and it looked like the group that had naltrexone for 6 months, even though they knew they weren't taking any pill, they still looked better than the other 2 groups. Now, I never published that study because the results were like P equal 0.06, so they didn't quite meet the statistical criteria for being significant.
What does that mean for those of us who speak English?
Yeah, so when we do research, for something to be, quote, statistically significant, it has to meet the P less than 0.05 criteria, which means the chance of it being random is less than 5%.
Okay.
So this was more like 6%. So there's 6% chance there was no differences, a 94% chance that there was something real going on. But in science, we arbitrarily say it needs to be less than 5%. And so it's hard to get a study published that doesn't meet the standard statistical significance criteria of P less than 0.05.
Got you.
So even though it didn't meet the standard, it's quite likely from this study that you should be on for 6 months rather than just 3 months. Okay, so that's the data. And I don't know, if somebody else has other research that speaks to this point, please send it to me because I don't know any other studies that have looked at it. Now, clinical hat. Okay. So again, $5, cup of coffee at Starbucks, but this is what I believe. The longer you stay on naltrexone, the better.
Mm-hmm.
Now, why is that? I believe, and this is where it gets into a longer talk, that recovery from alcohol addiction is more than not drinking.
Yeah.
That I know people who never took naltrexone, they would go to AA meetings every day, and they would not drink, and they would celebrate 6 months of no drinking. And I'd ask them how they're doing, and they say, I'm sort of doing fine. I go to meetings every day. I got a new coin. And do you think about alcohol all the time?
Mm-hmm.
Do you meet your friends at the bar? No, never. I avoid people, places, and things. What would happen if you don't go to meetings? I don't know. If I didn't go to meetings, it would be terrible. So their life still centers around alcohol, but they're not drinking. They're still thinking about it. They're still avoiding certain things, but they're in, quote, recovery. That's different recovery than someone who goes on naltrexone and says to me, I can take it or leave it. I can be around people drinking and it doesn't bother me. I've lost the desire to want to drink. And I think that takes long.
Yeah.
And remember I said I had an example I wanted to give you, and I would save it for later. Well, now it's later. So now I'm going to give you an example. And this speaks to the people who do the Sinclair Method and the idea that naltrexone only works by pharmacological extinction, if you will. So according to David Sinclair, he would have rats press a lever and they would get alcohol, and then he would give them naltrexone, and they would press the lever and no longer get the reward from the alcohol, and then the rats would extinguish their behavior. Mm-hmm. So pressing a lever to get alcohol is an example of what we call instrumental learning or operant learning, where you use your own muscles, you use your own behavior that you have control over to get some reward. And so he believed that by training and not getting the reward, the rat would learn not to press the lever to get the alcohol. The alcohol would stop being reinforcing. But that never made sense to me. Then why would it take so long for people to get better? Naltrexone is like something that blocks the key opening your front door. So it blocks the lock. Mm-hmm. Okay. So if you have a front door and someone gives you a key and the key doesn't work anymore, how long does it take you to learn this key doesn't work anymore? I bet it doesn't take very long. It doesn't take 3 months. It doesn't take 9 months. I bet that day you learn this key doesn't work anymore. So instrumental extinction should occur right away. So why does it take so long? It has to do not just with instrumental reward, it has to do with wanting, desire, motivation. If I told you your girlfriend lived in that house and now you had the key and all of a sudden she changed the lock, you might quickly learn this key doesn't work anymore, but you're like jamming it and messing around with it. Maybe you go back the next day and you try it. And it's because you want to get in the house, not because the key doesn't work anymore. You still want to get in there. And that's the other thing naltrexone does. It takes away the want. And that's not just instrumental learning. The wanting comes from cues associated with the event. Your girlfriend reminds you of all these wonderful times you had in life. So she becomes a conditioned stimulus for all these wonderful things. So you want to get in there, and that part of extinction takes time. It's like, let me use another example. If I go into a fancy steakhouse restaurant I get hungry. The cues of that restaurant get me excited to want to have a good steak dinner. Now, if I go in there and somebody says, well, you don't have any money to pay for the steak dinner, your card expired, so you can't pay for it, I would learn not to order the steak dinner. But that doesn't mean when I walk into the restaurant, I don't want to have a steak dinner.
Right.
If you take naltrexone over time, the steak dinner loses its power to elicit that I'm going to get a steak dinner here.
Yeah.
It's no longer associated with it. You're walking into a restaurant, but you don't have any expectations that you're going to get a steak dinner there. And that's what naltrexone does over time.
Yeah.
So how long should you be on naltrexone? I've had patients who lost the desire to drink, but then it was the 4th of July, and they went out with their family, and they went to a 4th of July picnic, and everybody was drinking, and all of a sudden they came back. They wanted to have the alcohol. Or it was the holidays for Christmas time or whatever. And everybody was drinking, having fun, punch and all that, and eggnog. The craving came back. The desire, which was gone in November, came back in December.
Yeah.
So I say at least have a whole year of holidays with naltrexone so that you can say, oh, last Christmas I had a great time. I didn't need the eggnog to have a good time. So at least the association with Christmas means drinking gets broken. That you can enjoy a 4th of July barbecue without having alcohol. And the longer you do that, the more the motivation, the desire to want to drink. Now, that's my theory.
Yeah.
And again, not based on science. Again, there's no good data how long you should be on it. But maybe, Katie, you can let us know what your experience is personally or working with patients, that why staying on naltrexone longer is better.
Yeah, I mean, in my experience, I just felt like naltrexone worked better and better the longer I was on it. Like the results I had 4 months in, I remember thinking, if this is all I get, this is great. I was drinking 3 days a week, wasn't blacking out anymore. But as I continued repeating drinking on naltrexone, having more alcohol-free days, it just got better and better. I was drinking less and less, desiring it less, to your point, going through holidays or difficult circumstances, and mindfully, do I want to drink? If I don't really feel like it, what else can I do? It took that effort. But I've worked with so many people, and I have stories on my channel on YouTube of, 2, 3, 4 years in, and they just continue to drink less, continue to see results. And to your point about what you said earlier about, the brain being more like a symphony orchestra where there's a lot of instruments at play, even with naltrexone, blocking some of those reward receptors, we still have all those memories and associations and, routines around drinking, which I think is why people say, oh, I didn't really feel like drinking today, but I did it anyway. Or I didn't feel like that third drink, but I always drink the bottle, so I did it anyway. And that's where we meet naltrexone halfway. Naltrexone's doing its job to give you a stop signal, but then memories, habits, behaviors come along that. So basically, because people do tell me, oh, it's not safe long term, but that's not true. There's no data to suggest that you should only be on it for a certain amount of time. Otherwise, it's dangerous. Is that right?
Yeah, and I'll give you an example. I saw a patient a couple of weeks ago, and this was someone that I started seeing like 2 decades ago, so 20 years in. And when I first saw him, his life was a mess. His wife was out the door. She was ready to divorce him, wasn't getting along with his kids. He's having problems with work. And he had social anxiety. He would drink to help deal with social anxiety. And so I put him on naltrexone, and he would take it every day. I think, did he do oral? I think he may even been doing the extended release naltrexone, the Vivitrol. And after about a year, he was doing great and stopped drinking. And over time, and this is like a couple of years, his wife actually came around and said, you are a pretty good man. But she would hold it over his head all the time about his drinking days, and he'd be all upset about that. But actually, they're getting along great now. The point is, his daughter was engaged, just got engaged. And so they had an engagement party. And so he had to give the toast. The the new bride, engaged woman who was going to get married. And so everybody has champagne or whatever in his glasses, and they poured him some champagne. But he knew he was going to give a toast. And so even though he hasn't taken naltrexone now for about 10 years or so he stopped the shots, he still carries around a naltrexone pill with him for these kind of situations. And just prophylactically, he took the naltrexone pill and gave the toast, had no desire to drink. It wasn't even like, oh, it's too bad I can't drink and toast. It was like, he had no desire.
Yeah.
And the fact that other people were drinking didn't affect him at all. He didn't care. He was just enjoying the moment.
Yeah.
Alcohol was completely irrelevant to him. It was completely irrelevant. And that for me is treatment.
Yes.
Not that someone doesn't drink, that's good, but treatment is when it doesn't matter.
Right.
When it doesn't matter. But how long? He stayed on naltrexone for a bunch of years. Then he stopped, but he still takes naltrexone even now, 20 years later, once in a while when he's in a high-risk situation.
Yeah, and that's like one of the hugest gifts of naltrexone is it takes away that desire. So it's not this fear. Because I was sober 6 months before I learned about naltrexone and TSM, and I was afraid to go to places. What if today's the day I relapse? Just don't drink today. And it just got louder the longer I was sober. It wasn't like that desire went away. But with naltrexone, to just not care, like I just don't care about drinking, that's incredible. Okay, so I know we're over time, but do you have a couple minutes? Because there's this one question I wanted to get to for this person, and they're also
Sure.
asking if you take new patients online. I don't know if they're talking to you or me, but you can mention that as well. But basically, it sounds like they're on opiate medication for chronic pain,
Mhm.
and they've also done bariatric surgery and have
Mm.
malabsorption issues. No NSAIDs. I don't know what that is.
No,
Maybe you do.
NSAIDs,
Okay.
non-steroidal anti-inflammatory drugs.
Okay. So they're saying, can you take benzos / Ambien with naltrexone? All other health issues A-okay. And then they're asking, what would you suggest for chronic opioid pain patient wanting to switch to naltrexone? What dosage? So of course, I know, again, we can't give medical advice, but generally speaking.
So again, let me answer generically,
Yeah.
and let me deal with a couple issues there. So number one, people who've had bariatric surgery are at much higher risk for developing alcohol use disorder. There's plenty of data to show that that's true. And it may have to do with how the alcohol is absorbed,
Yeah.
that it gets absorbed more quickly or whatever, gives you higher blood levels. I think there's data to show that you get higher blood levels with that. And people who've never had an alcohol problem, when they get bariatric surgery, have a much higher incidence of getting alcohol use disorder. So that's number one. Number two, if you're on chronic opioids for pain, you can't take naltrexone. I'm glad you pointed this out. The one contraindication, the one reason you should not take naltrexone is if you're on opiate medicines, because in your body, if you take naltrexone on top of opiates, it can bring on terrible withdrawal reaction.
Mm-hmm.
So you don't want to do that. Now, many doctors today are not excited about using opiates long-term for pain, because in general, your body gets used to the opiates and it doesn't work so well. And for some people, they get what's called hypergesia, that instead of getting where taking opiates, the pain goes away, it seems your body compensates for the opiates being in your system and you get more sensitivity to pain. It's called hypergesia. And so as we understand that, the idea of using opiates for chronic pain is losing favor. There's actually some data in animals and some clinical data in humans that for some reason low dose naltrexone, now I'm talking like 6 milligrams as opposed to like 50 milligrams, can help with pain. So curiously, low dose naltrexone may work very differently with respect to pain. That may actually help people with certain chronic pain conditions. And then certainly there's data to show that it helps people with chronic inflammatory diseases, but maybe with chronic pain conditions, the low dose. Now, for my patients who need to be on an opiate long-term for pain, I generally recommend using something more in the buprenorphine family, and there's something called a Butrans patch, which is low-dose buprenorphine that you can put a patch on, and it lasts for a whole week. And the idea is I like people not to have the idea of pain means take a pill, pain means I take a pill, because that sort of reinforces that pattern. But you stick a patch on, then you don't have to worry about it for a whole week. So if you have to be on some sort of opioid for chronic pain, buprenorphine is a little bit better choice. But there's a whole bunch of options. That's worth a whole hour just to talk about the pain, opioid, naltrexone system. And, we can spend some time talking about it. And it gets a little bit complicated. And again, talk it over with your doctor. But there's a variety of things you can do to help with the pain and not put yourself at risk for getting addicted to opiates.
Okay, I hope that's helpful to that individual who's here asking those questions. And if people want to get in touch with you, Dr. V, are you seeing patients or how does that work?
So I don't do this to generate new referrals. I've tried to take a really low profile and that sort of thing. I do have an office in Plymouth Meeting, and I have a staff of doctors who are enthusiastic about seeing new patients. And so if you call the Volpicelli Center, they can set you up for an appointment. But I'm trying not to see new patients myself, but I help supervise other people who see the new patients. I'm trying to train the next generation of doctors. And so I would peek over their shoulder, and I'm surprised no one has called me during this hour. Usually somebody from the office calls me with some clinical issue. But so I do that. And you, of course, have Thrive, which is really helpful to give the counseling and psychosocial support to help people in recovery. There's other online options for getting the naltrexone. I think somebody had a question about that they couldn't get a prescription for their naltrexone, but there's Choose Your Horizon. Was it RIA, I guess?
RIA Health, Web Doctors.
Yeah, Web Doctors. So there's a variety of options out there to get the naltrexone if your doctor doesn't know about it or is uncomfortable prescribing it. One other note that's good news, some really good news, and that is SAMHSA conducts a survey every year where they assess what percent of people in the country have alcohol use disorder or opiate addiction or whatever. And so they found that this year, the percent of people who have alcohol use disorder and are taking a medicine has gone up to 2.5%.
Gone up to?
You might say, ugh, that's terrible. And it is terrible, but it's a whole lot higher than it was last year. It's like a 26% increase.
Wow.
So something is actually happening out there that people are hearing about naltrexone. They're talking to their doctors about it. There's more interest in naltrexone these days. I can see it in some of the social media. I can see it in some of the Reddit subgroups that people are joining the naltrexone subgroup. So you can see that there seems to be a trend to using naltrexone more. And I supervise some of the residential treatment programs and IOP programs that traditionally are very sort of 12-step oriented in their approach to treating alcohol addiction. And they're now enthusiastic about using naltrexone. And so there's something happening. And 2.5% is still way too low. And I think my goal is we add a zero to the 2.5% and get up to 25% within the next 5 years. That's my moonshot. That's my goal. And that's what I'd like to see us accomplish. So that it shouldn't just be 2.5%, but at least 25% of people with AUD are being helped with some sort of medicine or some sort of effective treatment.
Yeah. It's pretty exciting and encouraging because in 2017, when I learned about naltrexone, telemedicine wasn't really a thing. There were some doctors doing it, but COVID really pushed that forward. But it took me a while to find naltrexone. And I know today some people who don't know about the online resources. I knew a woman who was literally paying for a flight to go to another state to see a doctor in person every month
Mm.
to get naltrexone. Like
Yes.
that's how desperate she was because she couldn't find a doctor. But then I told her about some of the online options. But yeah, I'm excited that it's so much more accessible and things are starting to change. Yeah. Okay. Gosh, this was a really great conversation. Thank you, Dr. V. As always, you're just a wealth of knowledge. People are thanking you in the chat. So appreciate you
Okay.
being here. And thank you to everybody who joined live. Thank you for the questions. Thank you to everyone who's watching this recording afterward. We'll hope to be back again here shortly. Any final words from you, Dr. V, before we wrap up?
No, just to say it's a pleasure being part of the community, and I get so much energy, talking with people who are so passionate about this and sharing my passion, and it's things are changing, things are turning around. So I'm really happy to see that after a couple of decades in the field. It's great to see that it's catching on, and I love to hear stories of people who are getting better and turning their lives around and being there for their family and being able to enjoy life again. This is great.
Yeah. And just thank you for your continued effort. You knew about this treatment probably before any one of us here, maybe some of us even before we were born, and you've just been persistent in the field. So thank you for all your work and research and advocacy. For those of you that don't know, Dr. V has formed a Naltrexone Alliance, which is do you want to talk a little bit about that before we wrap up, just so people are aware what that is as an organization?
Yeah. I'm trying to bring together, and it's working. People are coming together. People who have lived experience, people who do research in the area, people who treat patients, bring together a whole community of people who are passionate about bringing naltrexone to the larger community. And last year, I guess it's almost a year from now, that we met together. I met Katie, and it was great, and we gave presentations and talked and formed alliances and communities, and so we're trying to bring the message out there to people. And if you're interested in that, please, we have a website. We're still working on it a little bit, but we have a website, the Naltrexone Alliance, and it's part of our Institute of Addiction Medicine, the thing that I founded in 2008. And it's having a lot of really, I think, beneficial effects of getting the word out there.
Yeah.
And I guess I should always throw in a plug. I'm really terrible about this sort of thing, but if you want to contribute to it and that sort of thing, then I'll be able to afford the program that converts these things into smaller pieces, the Opus clips or whatever.
Yeah.
Yeah. So we'll be able to do more stuff if we get the kind of financial support to do that. But mostly it's just a labor of love from people donating their time and energy and talent. And we're trying to get the word out, and I think something's happening.
Yeah, absolutely. All right. Well, thanks again, everyone who joined. We'll hope to see you back again on another one of these lives with Dr. V. And I guess that's all. Okay. Sorry if we missed you too. If you left a question or comment.